This is Dr. Brown getting off work. All right. Well, today was another interesting day on the psychiatry awards. And when I first started this podcast, my original premise was I was going to talk about some cases that I actually saw like that day or, that week on the unit. And obviously I would scramble some of the data. So, yeah, I was going to talk about some specific cases and just not give the names and identifying information, obviously. And I asked ChatGPT about this idea, and it was like, oh, no, you can't do that because even though you're not getting any, obvious identifying information, it's still identifying because you're talking about cases that happened in a specific place. Like people could look you up and see where you work and know that you're talking about a case of the hospital there. So like their family member is listening to your podcast and they could identify that you're talking about their family. That's like, that's true. So haven't been able to talk about specific cases that I'm actively seeing or things like that. I do reference anonymized cases that happened a while ago. But yeah, the whole premise was sort of dead on arrival, the original premise anyways, because of HIPAA. And I'm glad I asked ChatGPT because even though I think I'm familiar with HIPAA, it's like sometimes those kinds of things don't jump out at you. So good to know. But today I thought I would talk about something more related to teaching. And so as someone who has taught residents and medical students and enjoys that aspect of the job, I thought I would chime in on teaching and mentoring. So one thing that I was really frustrated in with some of my attendings during residency training as a medical student is that, for one, they wouldn't often, many of them wouldn't actively teach. They just expected you to sort of take it all in through osmosis. And you definitely do learn a lot just by observation. And if you're good at paying attention to the details, then you can definitely learn a lot from that. But I think it is important for us as teachers, and as if you're a resident, then you're teaching potentially junior residents. If you're more senior resident, you're going to be teaching medical students. If you're a medical student, you might be teaching more junior medical students or pre-meds who are interested in going into medicine. Or obviously, if you're a fellow attending, then you're going to be teaching residents and medical students. So I think this applies to all of us at any stage of the journey through medicine here. But yeah, I think we should take time to explicitly teach. And it's hard because it's really busy. I mean, I had a pretty good day today where everything went smoothly. I only had one unexpected thing happen, which is unusual. Usually there's a lot of unexpected things that happen and your plan doesn't work out. So it's really hard to have a sit down lecture with somebody, right? So trying to teach in little bite-sized chunks, little moments throughout the day is really how you got to do it. The other thing that I wish I had more of as a psychiatry resident was what is sometimes called pimping, but this is basically just quizzing, on the spot quizzing. And I think this is very common in other specialties, especially the surgical specialties. I remember during my medical school rotations, getting quizzed on the spot was pretty much happening all day, every day. But it wasn't so common in psychiatry. And I think part of that's just the type of people that get attracted to these different specialties. I think part of it's also the fact that there's just different levels of risk in different specialties. So, if you're a neurosurgeon, pretty much everything you do is extremely high risk, right? Like any little move and you could kill the person immediately or severely debilitate them. Whereas in psychiatry, the main sources of risk are the patient's behavior, right? A patient might try to kill themselves or try to hurt somebody else or accidentally hurt themselves or accidentally hurt somebody else because they're in a state of psychosis. And that is, I don't want to say it's not our fault, but it's not our fault, but it's our responsibility as the physician to deal with that. So it's a little bit different than a surgeon where it's both their responsibility and their fault if something goes wrong like that. Of course, we are physicians as psychiatrists, and so we give medical treatments, whether that's um, medications or electroconvulsive therapy or transcranial magnetic stimulation, or what have you. And those certainly can have risks. Although, for the most part, our medications are relatively safe, all things considered. So far, knock on wood, I have not had any patients die from any of the from medications. So that is one thing. Nor have I had anybody die from ECT or any of the procedures. So from a medical treatment standpoint, our treatments are relatively low risk compared to other specialties. But so I think that goes a way toward explaining some of the differences in on the spot quizzing or pimping, as it's called, in the different specialties. But I also think psychiatrists tend to be just, how should I say this, more relaxed, or that's not the right word. They try to be nicer, I guess. Everybody's trying to be supportive of mental health, of course, right? So you don't want to stress people out, and pimping or quizzing people on the spot can be a form of stressing people out. But I think that's really wrong-headed, and it's sort of like, the parent who just does everything to appease their child and avoids any chance to make the child cry. So it's like optimizing for the short term over the long term. Because I think on the spot quizzing is actually a very effective teaching tool. One, because the slight amount of anxiety that you get when somebody quizzes you on the spot really helps you remember it, especially if you get it wrong. And two, the on the spot quizzing, the pimping tends to be quite relevant to what you're doing, right? So if I'm quizzing a student, I'm generally thinking of something in context. Like we just saw a patient, and then that makes me ask them a question relevant to that. So they're getting a little bit of anxiety to help them learn, right? There's an optimal amount, right? If somebody is extremely sensitive, maybe that'll inhibit their learning. But for most people, it's not going to be. It's actually going to be helpful. A little bit of anxiety helps you learn, helps you remember things, and doing that in context is the best. So I think this style in context on the spot quizzing is a really effective tool, and I would certainly advocate that it be used a lot more frequently than I think it is in psychiatry. So, anyways, the third aspect that I thought was lacking in my training is real-time feedback. And every training program, because of ACG, they're required to submit evaluation forms at the end of the rotations, things like that. But when you're an attending trying to fill out an eval for a medical student at the end of a rotation where you maybe did a few days with them, it's really hard to remember their performance unless they were exceptional in one way or another, exceptionally bad or exceptionally good. If they're somewhere in the vicinity of an average medical student, they're just another student, and just you don't really remember. So these kind of reflective feedback modalities are, in my opinion, very ineffective and not very useful. So I think you need to have real-time feedback, because the person giving the feedback is going to have the most relevant and useful feedback right after the feedback triggering event has occurred. So if you just saw somebody doing suturing, a medical student trying to learn how to suture on the surgical service, it doesn't make any sense to tell them how they did like a month later, right? You need to tell them immediately, like, no, that's not how you do it. You need to do it this way, or, next time you could do it better this way, right? But for some reason, we have this system where we tend to give feedback of like a month later or 2 weeks later or something like that. So those are the three things that I wanted to address as an attending. When I started teaching, I wanted to give real-time feedback. I wanted to give real-time feedback. I wanted to do on-the-spot quizzing for optimal in-context learning. And I wanted to have at least brief moments of explicit teaching. The other thing that I think is important is teaching not just the medical knowledge, right? I think what attendings, if they do any amount of teaching, they tend to get right is teaching the textbook stuff, right? This is the medication that you would use in this scenario. These are the side effects, right? These are the criteria for diagnosing this condition. Like that's all stuff that you can pick up in a book, but you're learning it in context when the attending teaches you on the wards or whatever. But there's also the decision-making aspect. Like, how do you actually think through things? How do you make good judgment calls? How do you synthesize a lot of data? How do you operate under conditions of uncertainty? And that's all stuff that is generally not taught in textbooks. And you're just supposed to sort of pick up through osmosis again. So I also wanted to incorporate that aspect in there, the clinical decision-making aspect. So I came up with a mnemonic, and it's called LETTER, LETTER. And this is a mnemonic that I use when hearing a resident or medical student present a case. So these are the situations where they've seen a patient, we've assigned them some patients. They have done maybe a history and physical, or this is just a, follow-up, and they're presenting the case. And so L stands for listen attentively. So we're going to listen attentively to the case presentation. We're going to avoid unnecessary interruptions, and we're going to take mental or written notes about their presentation. And rather than interjecting and interrupting their flow of the presentation, we're going to let them finish no matter how excellent or how terrible it is. And we're just going to jot down notes, and we'll be able to give feedback later. E stands for explore the trainee's thought process. You could also make it stand for engage in critical thinking. And basically, this is the part where we ask a lot of why questions, and we're trying to understand the trainee's clinical reasoning and decision-making process. So, for example, why did you decide to start sertraline as opposed to a different SSRI? Why do you think that this person meets the criteria for involuntary commitment? We're going to assess the quality of the trainee's risk assessment. This is also where you can ask, because this is something that's often missed by trainees, but what do you think this patient's suicide risk is? Are there any medical risks that we need to watch out for? Are there any potential psychiatric risks that we need to be aware of? For example, mania when we're starting antidepressant monotherapy. How can we mitigate these risks? So this is where we can really engage in critical thinking, ask the trainee to reflect on their care of the patient thus far, and offer self-assessment as well. Okay, so there's kind of a lot going on. It is the E part of the mnemonic. Moving on to the first T, that stands for test, and test medical knowledge specifically. So this is where we can do a brief in-context quizzing. And so we're going to ask some direct questions to test medical knowledge. And so this could be about differential diagnosis, prognosis, DSM-5 criteria, the known pathophysiology of a condition, mechanism of actions of treatment, potential side effects, black box warnings, informed consent, pharmacokinetics, mental status examination, physical examination, interviewing techniques, evidence-based practice, lab monitoring, ethical issues, medical legal issues, et cetera, et cetera. So based on their presentation, you're going to try to pick one of those categories and ask them a relevant question to quiz their knowledge. And of course, you're going to want to make that appropriate to their level of training. It might be helpful to bring a textbook or research journal article with you, during the time that you're going to be doing your feedback, so that you have a source of medical literature or medical knowledge from which to maybe get some quiz questions from, because it's, sometimes not always easy to just pull these things out of your head on the fly. The second T in the letter mnemonic stands for teach. And this is where we're going to just give some explicit teaching. So this might, if the trainee gets your test question wrong, then obviously you can teach them the right answer. And so that's where the second T can come in. But if they get it right, then you might have something to add on to that. So if your quiz question is, what do you need to do in informed consent when starting Abilify. Okay. And so they might, give a reasonable answer. And then you might say, yeah, that's very reasonable. Here are some other thoughts on the matter, right? Here's why that's important. And then last we have E and R, and those are kind of together. And that stands for encourage and reinforce positives. So this is where we're going to, you know, basically try to uh, reinforce the positives of whatever they did right in this and encourage them to, keep studying, keep learning, reinforce whatever they did well. So if they gave an excellent presentation, this is where you're going to reinforce that and really focus on specifics, because if you just said, you did a great job, that'll make them feel good, but it won't give them much to anchor on in terms of what they could do, what they need to repeat. So that is the letter framework that I found helpful. Again, that's L for listen attentively to a clinical case presentation. E for engage in critical thinking or explore the trainee's thought process. T for test medical knowledge. The second T for teach. And E and R for encourage and reinforce positives. So I'll leave it at that. That's my framework for teaching trainees in brief spurts that I think can be helpful. All right.